Welcome to AETCM, the emergency medicine channel. Shall I start? A 48-year-old male patient, non-case of hypothyroidism, old history of dengue fever in 2015 and meningitis in 2019, now presented to ER with complaints of fever, headache and multiple episodes of vomiting and confusion and lethargy for the past 2-3 days. On initial 10-second assessment, airway is patent, no gurgling of sound. Coming to breathing, respiratory rate is 14 per minute with saturation of 96% in room air and chest air entry bilaterally equal. Circulation, coming to circulation, BP is 100/60 mm of Hg and pulse rate is 52 per minute regular. And at that time, we inserted IV cannula and connected to the cardiac monitor, and one ECG was taken, which shows sinus bradycardia. And disability wise, patient is E3V4M5 and pupil bilaterally equal and reactive. Exposure wise, temperature is normal, febrile, and GRBS is 86.
What was the initial complaints?
Patient had history of fever, fever with chills associated with headache, bifrontal headache, and also multiple episodes of vomiting. And from on the day of arrival to the ER, patient also developed confusion and lethargy.
Okay. Anything significant in primary survey?
In primary survey, BP is 160 with the pulse rate 52. That is sinus bradycardia is there, but it's regular.
And hypotension?
And hypotension.
Going to hypotension.
Going to hypotension. And respiratory rate is also 14 with normal saturation 96-97 and disability is E3V4M5 and temperature is normal, GRBS is 86. Coming to the urgents, in CBC CRP point of care, HB is 11.2 with total counts of 15,600 and platelet count is 1,80,000 and CRP is 58.
So there is an underlying infection.
Is there. And we took one VBG which shows pH of 7.3 and bicarb of 48 and PCO2 of 48 and bicarb of 26 and PO2 is 86. Lactate is 2.5 and sodium is 122 and chloride is 90, potassium 4.8 and creatinine is 1.18.
So patient is having an underlying infection and ABG shows a hyponatremia also. Okay.
And ECG already taken which shows sinus bradycardia and at that time we done a USG chest which shows bilateral mild trace pleural effusion picture is there and chest x-ray is also taken which shows the similar findings and coming to ample history which shows the patient has no allergy to any medications. A 48-year-old male patient, non-case of hypothyroidism and history of dengue fever in 2015 and meningitis in 2019.
Since how long is he having hypothyroidism?
Since 5 years. And presented to ER with complaints of fever with chills started 3 days back, followed by diffuse headache and multiple episodes of non-bilious vomiting over the last 24 hours. And family also noted increasing drowsiness and lethargy and confusion since today, that day of morning onwards. And there is no history of any neck pain, blurring of vision and focal weakness or paresthesia. There is no history of seizures, no history of recent trauma or recent travel, no history of alcohol intake or drug overdose, no history of abdominal pain, constipation, loose stools, dysuria or upper respiratory symptoms or cough. History of irregular bowel habits is there, poor appetite is there, there is no addictions. Past medical history, his non-case of hypothyroidism for the past 5 years on irregular medications, initially on 150 milligram per day and that is changed into 100 mcg per day in last month. And he has a habit of taking irregular medications and he didn't take medicine for the past 1 week, hypothyroidism medication. And there is no history of diabetes, hypertension, CAD or CKD. He was hospitalized in 2015 for dengue fever and 2019 with meningitis. And coming to examination.
Is there anything significant in examination part?
Examination part, patient was drowsy but arousable. GCS is around 12 to 50 and patient is confused also. And general examination, patient is obese also. There is no pallor ictus cyanosis, clubbing. Lymphadenopathy, there is mild pedal edema is there, bilateral pedal edema. And on upper respiratory examination, there is no sinus tenderness for headache and no neck stiffness. And CVS S1 S2 heard and abdominal soft and non-tender. Bowel sounds are sluggish.
Nothing much significant.
Nothing much significant.
So here we have a patient who is a known hypothyroid, not on a regular medication, presenting with a confusional state. So what is the first thing that comes to your mind when such a patient presents to you?
Initially, patient presented with fever, headache, and multiple episodes of vomiting. We initially suspect, and with the CBCRP elevated, we initially suspected infection, either any CNS infection. So we initially, after CBCRP, VBGN, we proceeded with MRI brain with contrast to rule out any meningitis or CNS infections. So in MRI brain with contrast came out to be normal.
And clinical signs of meningitis were also not there.
Present.
So that is one thing. So if a patient, the main thing is in the background of, here the patient is having infection, that is true. So in the background of a patient who is hypothyroid and not on regular medication, and some in that background, when you see the case, it can be a myxedema crisis or a myxedema coma. Why is it called a myxedema coma? Patient is not in comatose state, no, but it is still called myxedema coma. Why?
Patient can be the Jesus.
It will keep on lowering. The patient does not present to you with a coma. Patient will come with the complaints of lethargy, drowsiness, which will slowly progress, and the patient will will go into a comatose state. That is what happens. So what is hypothyroid? What is primary and secondary hypothyroidism?
Primary hypothyroidism basically due to the intrinsic dysfunction of the
Thyroid gland. And common causes normally are?
Normally can be due to the Hashimoto's thyroiditis and also any surgical removal of the thyroid or radioablation, and also in case of drugs, lithium, alpha interferon or interleukins,
amiodarone, all these anti-tubercular drugs and all will cause hypothyroidism. So those patients, so we have to look for any thyroidectomy scars or ask for any history of radioactive iodine ablation, etc. has to be asked. So if a patient presents to you with primary hypothyroidism, what will be the lab values? I'm talking about the thyroid profile.
TSH will be high and T3, T4.
Yeah, production T3 and T4 will be low. So what about secondary hypothyroidism? What is secondary?
Hypothyroidism is due to either the deficiency of TSH from the thyroid stimulating hormone from the pituitary or thyroid releasing hormone from the hypothalamus.
So it is secondary and tertiary we say. Secondary is because of pituitary abnormality, and tertiary is because of hypothalamic abnormality, and the common causes that we see are tumors, pituitary adenomas, any surgery done or any radiation received, or any in case of infiltrations like sarcoidosis, hemochromatosis can cause. So in that, the lab values of the thyroid profile will be both TSH, T3, T4 will be low. Okay. So what is, there are certain precipitating factors. So a myxedema coma comes to a patient who is having a background of hypothyroidism, which aggravates just like a DKA precipitating. So there are certain precipitating factors in myxedema crisis. What are the precipitating factors?
Infections can precipitate.
Most commonly infections, or it can be trauma or any acute surgery or any acute event like stress events like GI hemorrhage, CVA, MI, heart failure. Anything can precipitate cold exposure. These things can precipitate a myxedema crisis. So if a patient presents to you with myxedema crisis, what will be the clinical features of a myxedema crisis? Clinically, when you see with this, keeping this in background, what do you see in a patient with myxedema crisis?
The patient can be in sinus bradycardia will be there, hypotension, hyponatremia will be there. Patient can be lethargy, confusion, can be comatose. And
patient can have hypoglycemia, decreased, altered mental status, bradycardia,
hypoventilation will be there, hypercapnia and hypoxia will be there.
Yeah, these and all are features of this myxedema crisis. So once we doubt, this is the thing, other than the investigation of the infection part, what do you order? What are the investigations or lab values that you order in order to confirm your diagnosis?
We will send for TSH and free T3, T4 levels, and also we can send serum cortisol to roll out
Why
the
do you
secondary
send
causes.
serum cortisol?
To roll out the
If it is central or not, if it is central hypothyroidism or not, or sometimes patient can have secondary adrenal insufficiency. So you check for serum cortisol also. Okay, so once the lab values are done, so and so patient comes to you. Why does the patient have hypothermia in this case? This case patient is having an infection also, but in this case the patient is having normothermia, not hypothermia. Why?
Underlying infection
has
possibly temperature will
so always in a patient with myxedema coma, if his temperature is normal, not less, then you have to suspect some underlying infection. Okay, and what will be your line of management? How do you approach this patient? What will you do?
We have to approach in case of airway breathing circulation itself. If the airway is compromised and the saturation is too much low and there is hypoventilation and hypercarbia, then we have to intubate the patient. Otherwise, we
why will that happen? Why does the respiratory drive go? Because of the respiratory central drive will decrease,
and also there will be thickening of the chest wall in case of chronic
hypothyroidism. So that is one thing.
And upper airway. Large tongue and macroglossia.
This can obstruct the airway, so you have to protect the airway. And look at the saturation. If the saturation is not maintaining, you have to give supportive oxygen. And okay, after
coming into
airway and breathing is over, then.
And next in circulation, if there is sinus brady and hypotension, we have to give fluids. If it is still persisting, we have to give.
Why are you giving fluids in this case? Hypotension is not. It is not hypotension. Hypotension is there, but the main problem is thyroid hormone deficiency. So we can give thyroid hormone deficiency. Why are we giving fluids then? Because thyroid hormone, it takes time for it to act. So you can't just wait for give thyroid hormone replacement, and then we can't wait for that. So you start with IV fluids. Sometimes it doesn't revert even with IV fluids. So you start vasopressors as supportives. Okay. And other than that?
We have to supplement the thyroxine, and also we have to supplement hydrocortisone.
No, other than that, there are other supportive measures. Patient will be in hypothermia.
Then we have to do passive rewarming.
Like what do you do?
We can give warm fluids.
No. Passive rewarming is just blankets. You cover them with blankets. This warm IV fluids, hot air bags and all are active warming, which you should not do. Why you should not actively rewarm this patient? Because these will induce a peripheral vasodilation that will in turn reduce again worsen the hypotension. So basically for the temperature control, passive rewarming is what is preferred. And the other things like hyponatremia patient, we can do a fluid restriction. If the patient is having hypoglycemia, you can give dextrose. And why do you give cortisol, hydrocortisone or steroids? Why do you give, and how much do you give? What is the dose? 100 to up to 200 you can give. Why do you give hydrocortisone? We don't know what we, by the time serum cortisol levels are not come, so we are not sure. So why do you give hydrocortisone in this patient?
To bridge the time till the lab.
Not just to bridge the time, patient is in a metabolic stress and the thyroid hormone is not released also. So in order to cover up that, you give hydrocortisone, and hydrocortisone has to be given until and unless you rule out a secondary adrenal insufficiency. So that has to be there. It is in order to because of the metabolic stress that is developed in the body. So that are the supportive measures that you give, and you also have to start IV empirical antibiotics because the patient is having an underlying infection. So the main treatment is replacement of thyroid. So how do you replace? What are you giving? What is the thing that you give?
We have to give the IV correction, but it is not available in India. Actually, the IV correction is either levothyroxine, that is T3, or T4.
Levothyroxine is T4.
And
triiodothyronine is, or leothyronine is T3, which is preferred.
And levothyroxine is 4 mcg per kg.
What is the difference between T3 and T4?
T3 is more potent and T4 is peripherally controlled.
What is released by thyroid gland?
T4 is released and it is peripherally
T3 is also released, but the rate is 10:1 ratio. T4 is released more than T3, and T4 undergoes peripheral conversion to T3. What is the potency? In terms of potency, T3 is more potent than T4, but onset of duration of action and onset of action is different. T3 has a longer onset and a very short duration, just 1 day duration, whereas T4 has a duration of 7 days. So you preferably give T4 normally. So what is the dose of levothyroxine that you give?
That is 4 mcg per kg IV, usually started with 200 to 400 mcg.
In elderly, you give only 100.
Followed in 24 hours, and it is followed by 100 mcg IV, then 50, then until oral medication is tolerated. In elderly, usually we start with lower doses, that is 100 mcg IV. And in case of leothyronine, we started with 20 mcg of loading dose, followed by 10 mcg every 8 hours until oral medication. And
in elderly people and those with cardiac abnormalities, you give a lower dose. Normally they say that we have to start with T4, and even in case the hemodynamic instability or the respiratory efforts are not improving with T4, you start on T3. But recent articles, they say that you have to start both simultaneously, because the onset of action of T4 is very late. So you give T3 and T4 together. That is the thing. So in both the conditions, start with IV and then convert to oral. So what is the oral dose? How do you calculate the oral dose?
1.6 microgram.
No, oral doses the corresponding IV dose divided by 0.75. This is the oral dose of thyroid. And okay, so that is the correction of this thing, and then you have to correct the underlying pathology. So mainly you have to know what are the things that precipitate a myxedema crisis, and what are the supportive measures, and what are the mainstays replacement of thyroid hormone.